Hello everyone, we are from SGD 1 and right now we are going to present our presentation about our student projects entitled Pheochromocytoma. Next. Okay, let me introduce myself. My name is Richard Timothy Alcornia with last 3 digit of student number 006. So now I'm going to explain about the background of our student project. So the pheochromocytoma is a rare neuroendocrine tumor that is located in the adrenal medulla gland that can produce catecholamines. And it is this type of tumor is derived from sympathetic or parasympathetic nervous system's chromaffin cells. Meanwhile, the term for the extra-adrenal chromaffin cell cancer is called paragangliomas. The incidence of this kind of tumor is only about 0.8 in 100,000 per year. And the first case of this tumor is it was discovered by Dr. Charles Mayo in 1937. And this type of tumor is 90% sporadic and 10% familial. And it's also studied that pheochromocytoma is also related with the von Hippel-Lindau syndrome, the neoplasia type 2A, multiple endocrine neoplasia type 2B, and neurofibromatosis. Most of these tumors are benign, and it's only about 10% of pheochromocytomas that are malignant. And the diagnosis of this tumor includes laboratory and imaging tests. Meanwhile, the malignancy in pheochromocytoma is usually diagnosed by the metastatic disease or the local invasion, because this type of tumor is hard to diagnose microscopically, and the etiology of this disease is remain idiopathic. Thank you.
Hello, my name is Pheochromocytoma with 3 last digit student number 032. These are the problem identification of this paper. Okay, the purpose of this student project are to know the importance to understand the definition, epidemiology, pathophysiology, grading, risk factor, symptom, diagnosis, treatment, and prognosis of pheochromocytoma. Okay, for the significance of this student project, the clinician will be able to know how to manage and give effective treatment to patients with pheochromocytoma based on evidence-based medication and prognosis.
Hello, my name is Putri Agnes Monica with 3 last number student 100. Let me explain about the definition of pheochromocytoma. So, pheochromocytoma is neuroendocrine neoplasm that begin in the chromaffin cell of the adrenal medulla. So, pheochromocytoma can causing the hypersecretion of catecholamine that consists of norepinephrine and epinephrine. So, the classic triad for pheochromocytoma is palpitation, headache, and profuse sweating. For the epidemiology, pheochromocytoma affect 2 until 8 people out of every million people per year, and this disease can occur at any age, but commonly occur at 5 decades of life, and it occurs same rate in female and male.
Dr. Hello, my friend. My name is Naraswara, student number 135. So I would like to tell you about pheochromocytomas. They believe that they may arise from a mature adrenal medullary chromaffin cell with secreting an excessive amount of catecholamine and subsequent stimulation of adrenergic receptor, but the real pathophysiology is still unknown. But they believe that this mechanism play an important role in pheochromocytomas. Catecholamine modulating the majority of physiological functions such as vascular tone, increasing heart rate, cardiac contractility, breathing rate, muscle strength, insulin secretion, sodium reabsorption, and a variety of metabolic process, as well as glycogenolysis, gluconeogenesis, and lipolysis by the exposure to stimuli to maintain homeostasis and protect the body from organ malfunction. Thank you. Next.
My name is Chokodeh Sintan Dalmskawati with 3-digit of student number 231, and I would like to continue the pathophysiology. So the source for synthesized in catecholamine metabolism is protein called L-tyrosine and converted into norepinephrine by the enzyme called dopamine beta hydroxylase and then stored in the vesicular storage granules. And then it leaked into the cytosol and meets the enzyme called PNMT for the conversion from norepinephrine into the epinephrine. However, the continuous stressful stimuli, which is biochemical, physical, or emotional stressor, such as agitation, possible psychosis, can lead the surge in dopamine level, which is causing the increase in epinephrine and norepinephrine production. The condition with highly elevated plasma catecholamine levels, overexpressive and uncontrolled secretion because of large number of stimuli, can cause the influence on the cardiovascular system and the effect systemic such as hypovolemic form of hypertension, tachycardia, enhanced myocardial contractility, arrhythmia, and other causes like hyperglycemia, hyperlipidemia, and increased oxygen consumption. Next.
Good afternoon. My name is Claudia Felicia Limanda with the number 19025111058. Now I will explain about the grading of Pheochromocytoma. So there are two ways that Pheochromocytoma can be graded. The first one is using the Pheochromocytoma of the adrenal gland scale score, or the PASS. It scored 12 parameters with the maximum score is 20. And if the score is less than 4, then the tumor has a metastatic potential. But if it has the score more than 4, it does not have a metastatic potential. The next one is the grading of adrenal Pheochromocytoma and paraganglioma, or GAPP. It scored 6 parameters and had the maximum score of 10. If the score is 0 until 2, it is well differentiated and it will not metastasize easily. If the score is 3 until 6, it is moderately differentiated with a moderate risk. And if the score is 7 until 10, it has a high risk of metastasization. Thank you.
My name is Christian Basiantalo, number 075. For the risk factor, there are 4 factors. The first one is inherited syndromes and gene change. Between 25% until 35% of pheochromocytomas is linked to hereditary syndrome. The second one is age. A pheochromocytoma is commonly occur between 30 until 50 years old. And the third one is gender. Both men and women have an equal chance of developing a pheochromocytoma. And the last one is race or ethnicity. People from all races can be diagnosed with pheochromocytoma, but the tumor is less common in African American people. Thank you.
Hello, my name is Rosa Baludin Priyatna with pseudo number 115. So for the diagnosis, it can be suspected with complete anamnesis and a tour of clinical evaluations. For the diagnosis step, it uses biochemical evidence, catecholamines, which is metabolized within the chromaffin cells to metanephrines, and this intratumoral process occurs independently of the catecholamine release. Its biochemical markers give different percentages of sensitivity and specificity, which will be explained after this. The blood sampling must be done at the supine position for about 15 to 20 minutes of the IV catheter insertions with no food, caffeinated beverage, adverse physical activity, and smoking 8 to 12 hours prior to testing. Error in blood samplings and misinterpreted might result in false positive test results. The abnormal results therefore used to determine the need for an immediate tumor localizations in addition to the biochemical tests. Either CT or MRI can be used. CT scan is the preferred imaging modality because of its outstanding spatial resolution. Meanwhile, the MRI is reserved for metastatic condition, allergy to CT contrast, and in whom radiation exposure should be limited, such as pregnant women and children. Thank you.
I'm Vicky Samantha with the last 3 digit of student number 079. So, pheochromocytoma have a triad symptoms of headache, palpitations, and diaphoresis. It can also cause pallor, nausea, flushing, constipation, and weakness. And in a worst state, episodic anxiety and tremor could happen. Also, acute heart failure such as arrhythmia and myocardial infarction. Hypertension is also quite common. It may be paroxysmal or persistent, and some patients are normotensive due to hypovolemia, downregulation of alpha-1 androgenic receptors, or increased production of endogenous vasodilators.
My name is Brian Gervais Delis, last digit number 053. As mentioned before, in case of clinical suspicion of pheochromocytoma, the diagnostic step relies on biochemical evidence or biomarker of catecholamine production by the tumor. The catecholamine themselves are metabolized within chromaffin cells to metanephrines, and thus this is what we use as the biomarker for this pheochromocytoma. As we can see in this table, the highest sensitivity and specificity of biomarker is the plasma normetanephrine and metanephrine, with almost 100, 99, 94, and 89 of sensitivity and specificity in both children and adults. Next, there is a plasma norepinephrine and epinephrine, urinary metanephrine and metanephrine, urinary norepinephrine and epinephrine, and urinary vanillyl mandelic acid, with the best being plasma normetanephrine and metanephrine. Thank you.
Good afternoon, my name is Bella Sagung Saraswati, number 152. Treatment. Surgical excision is the most effective method for treating pheochromocytoma. After tumor removal, there can be significant hypotensive episodes and are associated with a sudden decrease in catecholamine levels. To achieve minimal intraoperative risk, appropriate preoperative medical treatment is required to block the effects of catecholamines at least 10 to 14 days before surgery. Adequate preoperative alpha blockage has been shown to reduce the percentage of perioperative complications to less than 3%. Most commonly performed surgery is adrenalectomy method. Other types of adrenal surgery are LTA, PRA, and robotic surgery. 5-year survival rate for patients with small pheochromocytoma that has not spread is about 95%. Meanwhile, patients with relapsed pheochromocytoma or has spread to other body parts have a 5-year survival rate between 34% and 60%.
Hello, my name is Udayana with last 3 student number 175. So the conclusion of this student project is pheochromocytoma are neuroendocrine neoplasm that begin in the chromaffin cell of adrenal medulla that biosynthesis and hypersecrete catecholamine and other proteins such as epinephrine, norepinephrine, and metanephrine. The disease affects 2 until 8 people out of every million people per year. Pheochromocytoma's pathophysiology was caused by adrenomedullary chromaffin cell, which secreted an excessive amount of catecholamine and subsequent stimulation of adrenergic receptor. Grading of pheochromocytoma used 2 scoring system. First, pheochromocytoma of adrenal gland scale score or PASS, and second, grading of adrenal pheochromocytoma and paraganglioma or GAP. Inherited syndrome, gene changes, gender, age, and race are a few factors that may raise a person's risk of tumor, but the risk factor of pheochromocytoma is remain unknown. Triad symptoms of pheochromocytoma are headache, palpitation, and diaphoresis. Some tests can be used to diagnose pheochromocytoma, such as biochemical tests, blood tests, and imaging tests. Most effective method to treat pheochromocytoma is surgery excision, and don't forget to provide preoperative medical treatment is required to block the effect of catecholamine at least 10 until 14 days before surgery. This disease can progress to metastasis and may recurrent after resection in some patients. Therefore, routine imaging and testing of plasma or urinary metanephrine are essential for the prompt diagnosis of recurrence.